WILMS tumor, nephroblastoma is an renal disease. Look at this picture, shows the tumor in kidney is of children's. Ultrasound findings, look at this, CT and MRI findings. Detail going on. Introduction. WILMS tumor, also known as nephroblastoma, is a rare type of kidney cancer, primarily affecting children, typically between the age of 3 and 4. It is one of the most common pediatric malignancies, accounting for about 6% of all childhood cancers. Named after the German surgeon Max WILMS, who first described it, the tumor originates in embryonic kidney cells and often presents as a painless abdominal mass. Etymology. The term WILMS tumor is named after Dr. Max WILMS, a German surgeon and pathologist who first described the condition in 1899. The word tumor derived from the Latin tumere, meaning to swell, reflecting its nature as a solid mass. Definition. WILMS tumor, also known as nephroblastoma, is a rare kidney cancer that primarily affects children, usually under the age of 5. It typically presents as an abdominal mass, sometimes with symptoms like swelling, pain, hematuria, or hypertension, and has a high survival rate, with prompt treatment involving surgery, chemotherapy, and sometimes radiation therapy. Types. 1. Unilateral WILMS tumor affects one kidney, most common. 2. Bilateral WILMS tumor involves both kidneys, accounting for about 5% of cases. 3. Sporadic WILMS tumor occurs without a family history. 4. Syndromic WILMS tumor associated with genetic syndromes such as WAGR syndrome, Dennis-Drash syndrome, Weidman syndrome. Causes. WILMS tumor arises due to genetic mutations affecting kidney development. Key factors include 1. Mutations in the WT1 or WT2 tumor. Suppressors genes on chromosome 11. to epigenetic changes impacting growth regulation. 3. Environmental factors, though less defined, may contribute in sporadic cases. Risk factors: 1. Genetic syndrome, WAGA syndrome, Dennis-Drash syndrome, and Beckwith-Wiedemann syndrome. 2. Family history, increased risk with familial causes of WILMS tumor. 3. Race or ethnicity, more common in African American children and less common in Asian children. 4. Congenital anomalies such as hypertrophy, one side of the body larger than other, cryptorchidism, and hypospadias. Complications: 1. Metastasis to the lungs, liver, lymph nodes. 2. Hypertension due to kidney involvement or secretion of renin. 3. Recurrence after treatment. 4. Renal dysfunction or chronic kidney disease. 5. Psychological impact on the child and family. Pathophysiology: WILMS tumor develops from undifferentiated metanephrotic blastoma cells that fail to mature into functional kidney tissue. Mutations in tumor suppressor genes WT1 or WT2 lead to unchecked cellular proliferation and tumor growth. The tumor is typically encapsulated but may invade adjacent structures or metastasis. Pathophysiology of WILMS tumor, a step-by-step process. WILMS tumor or nephroblastoma is a rare pediatric kidney cancer that arises due to genetic and developmental abnormalities. Here is step-by-step explanation of its pathophysiology. 1. Embryological development of the kidney. 2. Genetic mutations. Mutations in kidney genes involved in kidney development and tumor suppression leads to the initiation of WILMS tumor. WT1 gene, WILMS tumor 1, WT2 gene. Other implicated genes: CTNNB1, beta catenin, WTX and TP53. 3. Failure of mesenchymal differentiation. These cells fail to mature into normal kidney structure, creating a disorganized mix of blastema, primitive undifferentiated cells. Epithelial cells, immature tubular and glomerular structures. Stromal cells, supporting tissue, often abnormal. 4. Loss of tumor suppression and cell proliferation. 5. Angiogenesis. 6. Tumor expansion and local effects. 7. Metastasis. WILMS tumor primarily spread through hematogenous routes to lungs, most common site liver. Occasionally lymph nodes or other distinct sites. Eight, host response. 9. Clinical manifestation and diagnosis. Common presenting features include an asymptomatic abdominal mass, hematuria, and sometimes pain. Understanding the pathophysiology aids in tailoring treatments such as surgery, chemotherapy, and radiation to target the specific mechanisms driving the tumor. Signs and symptoms. 1. Abdominal mass, non-tender, firm and smooth, often noticed by patients. 2. Abdominal pain, may be due to tumor growth or rupture. 3. Hematuria, blood in the urine. 4. Hypertension due to renin secretion or vascular compression. 5. Fever, secondary to tumor necrosis or infection. 6. Weight loss and fatigue, late stage symptoms. Diagnosis. 1. Physical examinations, palpation of the abdominal mass. 2. Image studies. A. Ultrasound, initial screening. B. CT, MRI, detailed evaluation of tumor size, location and metastasis. 3. Biopsy or surgical resection, histopathological confirmation. 4. Laboratory test. A. Urine analysis for hematuria. B. Blood test for renal function and anemia. 5. Genetic testing. Identification of WT1, WT2 mutations in syndromic cases. Nursing diagnosis. 1. Acute pain related to surgical intervention or tumor pressure. 2. Risk for infection related to immunosuppression from chemotherapy. 3. Impaired physical mobility related to abdominal discomfort. 4. Anxiety, children and family related to diagnosis and treatment. 5. Imbalanced nutrition less than body requirements related to treatment, side effects. Management, medical management. 1. Surgery. Nephrectomy to remove the affected kidney and tumor. To chemotherapy, use pre and post operatively to shrink the tumor and eradicate microscopic disease. 3. Radiation therapy for advanced stages or recurrent cases. 4. Targeted therapy for specific genetic mutations. Ongoing research. Nursing management. 1. Monitor vital signs and assesses for signs of complications, example infection, bleeding. 2. Provide pain management using prescribed medications. 3. Support nutritional needs with high protein, calorie dense meals. 4. Educate the family on treatment regimes and home care. 5. Facilitate psychosocial support through counseling and support groups. Treatment options. 1. Nephrectomy, surgical removal of the tumor and affected kidney. 2. Chemotherapy, regimens such as Vinscritin, acetinomycin D and doxorubicin. 3. Radiation therapy, localized treatment for advanced stages. 4. Targeted therapies and immunotherapy, experimental options. 5. Supportive care, pain management, infection control and nutritional support. Psychosocial medicine. 1. Counseling for both the child and family to address emotional distress. 2. Support groups, counseling with other families facing similar challenges. 3. Educational support, ensuring continuity of schooling. 4. Play therapy, helping the child express fears and emotions. 5. Caregiver respite programs, offering temporary relief for parents. Prevention. 1. Routine screening in high-risk children, example those with genetic syndromes. 2. Genetic counseling for families with a history of WILMS tumor. 3. Prenatal care to identify congenital anomalies. In conclusion, WILMS tumor is a highly treatable pediatric cancer with advancement in surgical techniques, chemotherapy and radiation therapy, significantly improving survival rates. Early diagnosis and a multidisciplinary approach are crucial for optimal outcomes. Addressing the psychosocial and educational needs of the child and family is equally important in providing holistic care. Continued research into targeted therapies and genetic mechanisms holds promise for even better prognosis in the future. Thank you. Have a nice day.